Thank you. I'll try to be quick. I know I'm standing between you and lunch, and a few of your colleagues have been very enthusiastic about getting to lunch, but I'm happy to give this presentation on behalf of Johnson & Johnson, and I'll show you my conflicts of interest. I was going to give you a case scenario to begin. This is a case of a 25-year-old woman, the history of scalp psoriasis, which has been well controlled with topical therapy and a previous cholecystectomy. She's diagnosed 2 years with Crohn's disease and has an A2L3B2 disease phenotype with actually an early ileal stricture at presentation. She was induced with a prednisone taper and she's been maintained on methotrexate and comes in with active symptoms, active inflammatory markers with an iron deficient pattern, and an ultrasound in the clinic that, as we've heard, shows a 4 millimeter ileal wall with some loss of stratification and hyperemia consistent with active disease. And she does mention that she's very keen to minimize IV therapy. She said some traumatic IV starts in the past. And the question is what you'd offer to this woman as an advanced therapy. And we actually have Dr. Crone himself looking very skeptically at you, awaiting your advice on managing this patient. So we've seen this image before, perhaps not surprisingly. It's the most commonly shown cartoon on the left, but ideally we'd like to be able to prevent Crohn's disease. I know that if people before disease onset, and there's actually a trial starting to answer that question in Europe. But really where we are right now is really focusing on early diagnosis and early intervention, and perhaps more importantly, early control of inflammation in order to prevent that progression to fibrotic disease and penetrating disease, which is really the source of comorbidity, poor quality of life. And once patients are there, it's very hard to pull them back. And we do have some data that's possible. The charts on the right are from a Korean cohort showing that those who received early therapy are less likely to progress to surgery, penetrating and stricture complications. So there is value to early effective therapy. What do we have in our toolkit for this? Well, many classes of therapy in 2025. We have leukocyte trafficking with S1P receptor modulation, anti-integrin therapy, anti-TNF therapy, JAK inhibition, and of course the family of IL-12/23 and IL-23 therapy as well, and many other potential targets on this cartoon that may bear out in the future, as you know, as this is a very rapidly evolving area. The IL-23 story goes back a couple of decades, and this is one of the earliest data points suggesting it played a pivotal role in the pathogenesis of Crohn's disease, not only IL-23, but the entire Th17 pathway. This is a genome-wide association study with a number of illustrious authors led by Judy Cho, linking the IL-23 gene with the clinical phenotype of Crohn's disease. Fast forward through many other sources of evidence. This paper appeared a couple of years ago, which I've always found very informative and challenging. It suggests that we should reframe our approach to immune-mediated inflammatory disorders, moving away from an organ-based concept where gastroenterologists sit separately from rheumatologists and dermatologists, towards more of a cytokine signature-based approach to disease, where you look at the inflammatory phenotype and choose therapy on that basis. And if you follow that, I can't point, but in the IL-23 column, IL-23-driven disorders might include psoriasis, psoriatic arthritis, and inflammatory bowel disease, where anti-IL-23 therapy arguably is a very disease-specific intervention, whereas TNF is a target common to all these immune-mediated inflammatory disorders, perhaps is more of a downstream effector cytokine. So anti-TNF therapy, as we've heard, is more broadly effective. So what do we have to target IL-23 if you think it's a useful target? Well, really, we have both anti-P40 therapies and anti-P19 therapies. Ustekinumab has been with us the longest. Originally conceived as an IL-12 antagonist, but ultimately I think is now thought to exert most of its efficacy through antagonism of IL-23. So all of these should be considered IL-23 antagonists. And just to remind you of the pivotal clinical trials supporting ustekinumab efficacy in Crohn's disease, this is the Unity 1 and Unity 2 trials. Unity 1 looking at a population of patients with previous anti-TNF exposure. Unity 2 looking at patients who'd only failed so-called conventional therapies, really showing good efficacy compared to placebo. And the Unity 2 in a naive population, really doubling the rates of both clinical response and clinical remission. And so very effective, and I can say in North America, very popular therapy for Crohn's disease as a result. If you try to put this in context, this is a systematic review a couple of years ago looking at anti-P40 and anti-P19 therapies for Crohn's disease, looking at the outcome of clinical remission. If you just skin down in terms of the overall effect size with ustekinumab compared to P19 inhibitors, actually very much in the same ballpark in terms of the risk ratio for achieving clinical remission on therapy. If you look at endoscopic response in Crohn's disease, again, it's a bit unfair because the Unity trials did not build in endoscopic outcomes to their design. It was only done as a sub-study in a small number of patients. The Galaxy trial did have a more conventional comparison of ustekinumab and placebo, but again, the estimates of effect size are broadly similar. Probably one of the best sources of data looking at efficacy of ustekinumab has been the Seaview trial, which was referenced earlier. This is the first head-to-head trial we had published in Crohn's disease, as was mentioned earlier, comparing adalimumab and ustekinumab in bio-naive disease. And I think to many people's surprise that this actually was really a draw at the end of the day. Similar overall efficacy with adalimumab and ustekinumab, but also similar cadence, a similar rapidity of onset. The curves are really overlapped, showing ustekinumab similarly effective to adalimumab, which I think we consider a very effective therapy for treatment of Crohn's disease. I think even more importantly in the Seaview trial was the endoscopic outcome, because this is probably the more rigorous data we have looking at the endoscopic effects of ustekinumab, showing equivalent rates of endoscopic remission with adalimumab and ustekinumab at week 52 in that bio-naive population. So one could argue that's adalimumab compared to ustekinumab. Is that a class effect? Can you consider ustekinumab similar to other anti-TNF therapies? And we did look at that. Again, it's led by my colleague Niraj and Rula at McMaster, using individual patient data from a number of published clinical trials with propensity score matching to create comparable patient cohorts on therapy. And the bottom line was the conclusion was very similar to what you saw in Seaview, that infliximab and ustekinumab had similar overall efficacy and similar speed of onset in a cohort of patients with Crohn's disease who were bio-naive. So again, very overlapping and similar efficacy with anti-TNF therapy. We've had a cluster of additional head-to-head trials published over the last year, initially with the sequence trial. And again, I'm sure most of you are familiar with this trial. This was a head-to-head comparison of risankizumab and ustekinumab for treatment of Crohn's disease, and importantly, Crohn's disease with prior anti-TNF failure. This is not looking at ustekinumab or risankizumab as a first-line advanced therapy. It was a positive trial for both co-primary endpoints, clinical remission at week 24, which was a non-inferiority analysis, and endoscopic remission at week 48, which was a conventional superiority analysis, and all of the secondary endpoints were significant as well. Exciting trial. I think the challenge with this trial has been two things. One, it is an anti-TNF exposed population, but secondly, it was an open label design, so participants were aware of which arm to which they were assigned to, and there was a significantly higher dropout rate in patients who were assigned to ustekinumab, and I think there's a suggestion that that higher and disproportionate dropout rate may have affected some of the estimated effect sizes in comparing these two therapies. So I think that's been its biggest criticism, is the open label design. Contrast that with the VIVID trial, which was a head-to-head comparison of mirikizumab and ustekinumab for treatment of Crohn's disease. This was a blended population of bio-naive and bio-exposed patients, and overall, and this was a double-blind, double-dummy study design, so participants were not aware of their treatment allocation. And this was really a negative trial, showing no advantage of mirikizumab over ustekinumab. Perhaps a slight numeric difference if you look at the bio-exposed population, but in the bio-naive population, really, I think no signal of any difference between anti-P40 and anti-P19 therapy. And the third trial we had published over last year was Galaxy, which was a head-to-head comparison of guselkumab and ustekinumab, again in a blended population. This was also a blind, double dummy design. It was significant in comparison to ustekinumab in the overall population, but in this analysis, looking at the combined endpoint of clinical remission and endoscopic response at week 48, it was the bio-exposed population where that difference was statistically significant. So I think there may be a signal that if there's an advantage of P19 over P40 therapy, it may be largely in a bio-exposed population, and I think we don't really have as clear a signal that there is a difference in efficacy as a first-line advanced therapy in a bio-naive population. So then the question comes, can you transition from anti-P40 therapy if you use that first line to anti-P19 therapy as a second line? We don't have good data on that in inflammatory bowel disease, but this was a dermatology study that really looked at that question. This was Navigate, and for treatment of psoriasis. Patients in this study received first-line therapy with ustekinumab, and those who were non-responders were randomized to continue on ustekinumab or to switch from ustekinumab to guselkumab, and the switchers did better, so really kind of providing good evidence of a potential model for a sequential trial, a sequential treatment strategy starting with ustekinumab and moving to a P19 antagonist such as guselkumab. Well, that's all in the short term in terms of getting people better. How do people do over time? We do have long-term extension data with ustekinumab, and that's potentially one advantage of a therapy that's been around for longer. These are data looking at really 5-year outcomes in the long-term extension from the Unity clinical trial program. This first slide looking at all patients, the proportion of patients in clinical remission at entry into long-term extension and at the 5-year point in long-term extension, and really showing very stable retention of clinical remission, with most patients managing to maintain clinical remission over time. And I think that's something we see in practice, that once people hit remission with this family of therapies, it tends to be a fairly stable remission and a fairly durable remission. That's all patients. If we focus on TNF-naive patients, so we're using ustekinumab as a first-line advanced therapy, again, a very stable rate of remission over time. So what do guidelines tell us? Well, we're going to show this image again from the most recent ECHO guidelines. And I think it's already been pointed out, we have a number of therapies which are supported, which are in the green boxes for induction and maintenance of remission in Crohn's disease, and they include certainly ustekinumab. I think the interesting thing may be to the far right, if you look at the use in pregnancy, if you look at the use in an over 65 population where comorbidity is a concern, ustekinumab, vedolizumab are both supported and endorsed, and I think that speaks to perceived safety in a high-risk population, particularly the elderly population. So if you look a little bit further on safety, this was an interesting systematic review and meta-analysis published a couple of years ago, which I think created some controversy. This is pooled data from a number of observational data sets, as well as what head-to-head clinical trials were available, looking at the risk of serious infection on various classes of advanced therapy. And on the left, if you compared ustekinumab to TNF antagonists, there was a significantly lower risk of serious infection in Crohn's disease patients treated with ustekinumab. And if you look at the far right, and this is the interesting observation, when you compared patients receiving ustekinumab to those receiving vedolizumab, there was in fact a significantly lower infection rate in the ustekinumab-treated patients than in the vedolizumab-treated patients. That's surprising because I think we consider both of these to be very safe classes of therapy. The argument by the authors was that perhaps this reflected better disease control in the ustekinumab-treated patients, and of course poor disease control is itself a risk factor for infection. But certainly very robust safety data with ustekinumab. This was data presented a couple years ago at DDW from the EVOLVE expansion study. So it's a large multinational observational cohort of patients. And I just show you on the right, which is treatment persistence. Because to me, treatment persistence is a very useful outcome that kind of integrates efficacy, safety and patient acceptance of therapy, if they stay on therapy. And again, this was a comparison of vedolizumab and ustekinumab showing better retention on therapy with ustekinumab. We presented data recently from the Canadian Patient Support Program for ustekinumab. Again, this is looking at bio-naive patients, both Crohn's disease and early experience with ulcerative colitis, showing over 4 years very high rates of retention on therapy with ustekinumab. What I don't show you here is that the infliximab retention rates, because the patient support program in Canada includes both infliximab and ustekinumab, the infliximab retention rates were significantly lower. So you saw a much steeper fall off with infliximab than you did with ustekinumab. And lastly, some of this retention may reflect low immunogenicity. I think in the early days, we used to measure, do therapeutic drug monitoring with ustekinumab fairly routinely. We've stopped doing that more recently, but I've never actually seen an anti-ustekinumab antibody test positive, and I wonder if anyone in the audience has. But certainly, low rates of immunogenicity, I think, contribute to long-term retention on therapy, and of course, our ability to use this class of therapy as monotherapy without concomitant immunomodulators. So just to summarize, Th17 pathways and IL-23 itself are really critical to the pathogenesis of Crohn's disease. We have anti-IL-23 therapies, I think, do include both anti-P40 and anti-P19 molecules. Ustekinumab has good efficacy, both in bio-naive and bio-exposed patients, and I think we've got long-term data in bio-naive patients in Crohn's disease that show low sensitization rates, durable efficacy, and high patient retention. And even with the arrival of new therapies, I think ustekinumab does remain a key component of our IBD treatment algorithms. With that, I'll stop and show you a nice snowy picture of Canada. So thank you.